Hello, my name is Luke Austen. I'm currently a doctor working in anaesthetics and intensive care, and it's a great pleasure to speak to you today at the Health Careers Live National Health Careers Conference on this question of night mode. How can new healthcare professionals work safely at night? Which is based on a chapter from my book, The Bleep Test, How New Doctors Can Get Things Right. We'll start with a quote. "No man knows till he has suffered from the night, how sweet and dear to his heart and eye the morning can be," which is from Dracula by Bram Stoker. And I think it's something that will resonate with many of us who have done night shift in the NHS. Why is working at night so different and so difficult in hospital? Well, the hospital is a different place at night. Your footsteps ring out against empty corridors, which only a few hours ago were bustling with elderly people being pushed in wheelchairs, families visiting their relatives' wards, hospital charity volunteers recruiting for the fun run, and patients being transported to CT scans with their entourage of beeping monitors, equipment, nurses, and doctors. Now the commotion and hullabaloo of the daytime is gone. The humdrum and routine comings and goings of hospital life are finished for another day, and left behind are only the skeleton crew of staff deemed necessary to cope with the emergent and the urgent, the patients and the medicine that cannot wait until the sun rises and the hospital machine boots up once again. It is certainly true that whether you're a pharmacist on call, a chest physio coming into the respiratory ward, a nurse or a doctor, the work you're required to do over the night shift is fundamentally different and likely more challenging compared to that in the daytime. There are no routine prescriptions or routine referral letters to be processed. There's only the urgent tasks to look after the really sick patients who need us. Are hospital patients less safe at night? In 2010, Maggs and Mallet retrospectively analysed a year's worth of emergency admissions to a medium-sized district general hospital, finding that mortality was significantly higher for patients admitted out of hours compared with in hours, and for those admitted at night compared with during the daytime. Crucially, though, they only adjusted their data for age and sex, not for admission diagnosis or underlying comorbidities, acknowledging therefore that it was not clear to what extent the mortality differences were due to the patients admitted out of hours or overnight just being sicker to start off with. However, they did comment that the fact that the differences were still seen in late mortality, which were deaths occurring at more than 7 days since admission, as well as in overall mortality, suggested a strong role for patient factors at admission, since any variations in the healthcare quality provided arising around the time of admission would seem to have a much smaller effect on those deaths that occurred more than 7 days down the line. What about the effect of the night shift and working night on our own individual performance of those crucial tasks we need to do? In a 2018 report titled "Fatigue and Sleep Deprivation, the Impact of Different Working Patterns on Doctors," the British Medical Association highlighted the negative cognitive and psychomotor effects of fatigue and sleep deprivation on task performance, working memory capacity, and attention. Whilst their review did comment that the available evidence was limited, they pointed to multiple observational studies that linked self-reported fatigue-related medical errors to patient injury or mortality. They also highlighted a prospective randomized study that compared rates of serious medical errors made by critical care interns in the United States working shifts longer than 24 hours versus shifts of less than 16 hours. Unsurprisingly, interns on the rota that included these traditional extended duration shifts, which were more than 24 hours long, committed 36% more serious medical errors, 21% more medication errors, and 5.6 times as many diagnostic errors. Although these findings from the US are likely not completely generalizable worldwide, since their residency shifts are often dramatically longer than those in comparable healthcare systems, the key message is clear that accumulating fatigue is likely to decrease the safety of those patients in our care. So what else do we know about the effect of number of hours on shift or number of shifts completed on our chances of making mistakes? In a non-systematic review article titled "Shift Work, Safety and Productivity," published in 2003 in the journal Occupational Medicine, Folkard and Tucker combined data from 3 studies in different industries, into shift duration and accident risk, and found that the risk of accidents after 12 hours worked was approximately double that seen at 8 hours worked. So if you look on the left-hand side of the screen here, you can see on this chart that for the first 8 hours of shift, the relative risk, or mean relative risk, remained relatively constant, but increases dramatically in hours 8 to 12 of the shift. They also showed that there was an increase in risk across successive night shifts. Just look at that increased risk by the fourth night shift compared to the first, which I think supports the anecdotal feeling amongst most doctors that by the end of the fourth night shift, you're really approaching your limits for retaining an acceptable level of performance. This last graph on the right is also quite interesting, showing that the minutes since the last time a break was taken also contributes to the relative risk of accident. So, how can we best cope with this situation? What can we do to try and optimize ourselves, given what we know about our own physiology, to try and provide the best care for our patients? Well, strategies and techniques for coping with night shifts are common topics of conversation in hospital staff rooms, and lots of theories are around, but some are more accurate than others. One common misconception is that we can flip our body clocks when we do a set of nights. The first night shift is a bit rough, people will say confidently, but once I've synced into night mode, I'll be totally fine. It would be nice if this was true, but unfortunately it is a myth. We cannot flip our sleep-wake cycles. In the book Why We Sleep, Professor Matthew Walker explains that when he flies east from San Francisco to London, the sunlight signals to the brain's suprachiasmatic nucleus mean that he will eventually overcome the jet lag, but unfortunately the process is slow. It's much too slow. For every hour you're in a different time zone, he writes. So if every day you're in a different time zone, he writes, your suprachiasmatic nucleus can only adjust by about 1 hour. So for a doctor who is staying awake longer than their usual circadian rhythm is expecting as they come onto night shifts, which is our equivalent of rapidly flying east through multiple time zones, there is no hope of circadian resynchronization coming to our rescue. We would have finished our run of 4 night shifts before the process is even halfway done. However, the body clock flipping believers are right about one thing though. The first night shift usually does feel the roughest. This common observation actually has to do with a concept called sleep pressure, which is the second determinant of wakefulness, which, together with the internal circadian rhythm, governs whether or not we feel alert, fired up, and ready to go. In sleep physiology, these two key factors are referred to as process C for circadian wake drive, and process S for sleep pressure, which is mediated by accumulating levels of adenosine in the brain. Over the course of a normal 24-hour period, process C and process S work in tandem to keep us awake when we should be awake and to help us sleep when we should sleep. So in the morning, process C is ramping up and cortisol levels are increasing, combining with the low levels of sleep pressure at this early stage of the day to mean that we are appropriately wakeful. So when the distance between process S and process C is small, there is a strong urge to stay awake. Then, as the day wears on and process C turns the corner, decreasing the circadian wake drive, and sleep pressure continues to build as our hours awake accumulate, the distance between the two grows until eventually we fall asleep. Sleep washes out the accumulated adenosine, reducing process S back down until sometime after the circadian tide turns at its nadir around 4 a.m. The distance between process S and process C is small enough that we wake up and begin the cycle once more. Now consider what happens as we head into the night shift. You can probably see where this is going. So as we begin the night shift, process S will still be on the wake up, even if we have managed a successful little nap in the afternoon. Process C, meanwhile, is on the way down towards its lowest point, that nadir around 4 a.m. So for a 9 p.m. to 9 a.m. night shift, this means that the distance between process S and process C will constantly be increasing for the first part of the shift, progressively lowering our wakefulness. It is this high burden of accumulating sleep pressure, rather than circadian desynchronization, which makes the first night shift feel so bad. The interplay between process C and process S also explains a couple of other night shift phenomena, which most shift workers in the NHS will recognize anecdotally. That's the witching hour, or hitting the wall around 4 a.m., And that feeling of the second wind, when we feel like we actually have more energy for the last part of the shift, as the sun starts to rise and these light cues, which the Germans call Zeitgebers, from outside, combine with our rebooting circadian wake drive to help us temporarily feel better and function better, despite the fact that we've actually been awake and working for an overall longer period of time. So, using this knowledge of physiology, what steps can we take to help us minimize the risks for working at night and to help us keep our patients safer? So, there are 4 key areas. What we do before the first night, minimizing the sleep debt, that sleep deficit. What we do during the night to enhance patient safety. What we do between our night shifts to again minimize our sleep debt, and how we return to normality after the night shifts are done. So, but before the first night shift, the goal really has to be to minimize the sleep debt, so that we've got a bit less sleep pressure and urge to fall asleep once we've started working. So on that first morning, don't set an alarm and let yourself sleep as long as possible. And avoid caffeine early in that morning. The reason being that if caffeine is taken, even tea, which rather than coffee, which does still contain some caffeine, it can be harder to get a good quality nap in the afternoon, because caffeine's actually got a really long half-life in the body. So when you get to the afternoon, it's really important to try and have a nap, and ideally in multiples of 90 minutes, which is one sleep cycle, to avoid that horrible feeling of waking up between sleep cycles. During the nights, the goal is patient safety, so plan breaks within your team and create self-checks for safety-critical tasks, such as prescribing potassium, insulin, and anticoagulants, and beware that witching hour around 4 to 5 a.m., where the sleep pressure is really high and the circadian wake drive is right at its lowest point. So between the nights, again, it's difficult, but you've got to try and maximize the sleep that you get. So basic sleep hygiene is important, limiting screen time and not having any alcohol. Trying to invest in having blackout blinds and curtains, or even a sleep mask and eye mask. And if you do wake up in the daytime and find that you cannot sleep, get up for a short while, read a book, listen to the radio, but do try to then sleep again. And after nights, the goal has to be to return to normality. Rather than trying to stay up all day after the last night shift is done, it's better to have a short nap for a few hours, 3 hours, 4.5 hours, when you first get home, and then force yourself to get up. And although this can be unpleasant, hang in there, do a bit of light exercise, and then try to go to bed at a normal time on that day. There's one last area about working on night shifts that I think is really important to discuss. And this is the risks to ourselves as healthcare providers in whatever profession we're working in, if we're driving home from the hospital after night shifts. And the news clippings that you can see on the screen here relate to the sad case of Dr. Ronak Patel, who was a trainee anaesthetist who was killed driving home on a night shift in 2015. The Royal College of Anaesthetists conducted some surveys which give us some interesting information that illustrate just how risky it is for healthcare providers to be driving home after night shifts. So 57% of 2,231 UK trainee anaesthetist surveys had had an accident or a near miss on their journey home after a night shift. And in a subsequent survey, which featured consultants this time rather than trainees, 45% of those responding said they had had an accident or a near miss commuting whilst fatigued. But really interestingly, 72% of these incidents occurred whilst they were still a trainee, which tells us that this is when we are at the early stages of our career, when we are most vulnerable to having these kinds of accidents. And I'll finish with this note from Professor Walker in Why We Sleep that says, if you're drowsy while driving, please stop. To carry the burden of another's death on your shoulders is a terrible thing, and ultimately, it is just not worth the cost. So I do strongly think that if there's any alternative way to get home after a night shift, it's really worth considering. So thank you for listening to my talk about the night shifts. And if you found it interesting, there's lots more detail and lots of interesting other topics too about working as a young healthcare professional in my book, The Bleep Test, How New Doctors Can Get Things Right. Thank you very much for listening, and I hope you enjoy the rest of the conference today.